Why does root canal treatment, that perfect looking one, fails over time? I'm Dani Mancuso, specialist endodontist and prosthodontist, and today in this episode of the Diary of an Endodontist, I'm going to show you to you. This lower right first molar was treated by me to the highest standard, so if you know me well, I love the disinfection. This is the most important part of the treatment. So why has it failed if I confirmed that I could get to all the canals to the full length, measured with the apex locator? The patient reported that he had a crown done straight away, so there was no coronal leakage. So why has it failed then? Because for 3 years this tooth stayed completely asymptomatic, and after 3 years it developed something in the apex of the tooth because the patient couldn't bite on it, was having some symptoms, and there was a little bit of pain on palpation on the buccal sulcus. And as you can see on the scan, it's very clear that there is periapical radiolucency on both roots, the distal and the mesial. The tooth had a crown fitted straight after the root canal treatment, so there was no coronal leakage at that time, so it could be something that was like residual bacteria inside of the canals. But how can a good-looking root canal treatment fails if it was to the highest standard of disinfection? We could think of few things then. The first thing is coronal leakage. That's the most common thing. However, apparently it was not the case. The other thing is untreated canals. Again, we confirmed on the CT scan that there was no untreated canals. The next thing we think is apical radiolucency, is the apex we couldn't get to the length. But we did get to the length, as we confirmed as well. Then we have two options. Is either residual bacteria because there are some lateral canals, isthmus that were blocked during the treatment and we couldn't disinfect thoroughly, or we could have the apical third of the canal could be cracked from the press. So those are the two things. If it's cracked, we'll do the retreatment and it's not going to heal. Then we need to go for the apical surgery. But we shouldn't go for the apical surgery straight away. Mainly nowadays, it's quite easy to retreat those canals that we use the single cones and bioceramic. It's not a problem. So we decided then to retreat the tooth. I love when I see sealer puffs. It confirms that we access the whole canal and beyond. Our irrigants can go to the apex freely when we prepare that portion to a certain size. So I think when we did the root canal treatment, perhaps the patency was achieved because all the cases we achieved patency, but there was something. Either the irrigants, they didn't flow in that area, there was a lack of sealer in that area, because now we can clearly see a delta in the apex of the distal root. So I think that was the main problem. So retreating that tooth gives the opportunity for you to re-prepare that canal, enlarge a little bit, and disinfect a little bit deeper. Use your time to do the patency, to gauge your GP, and to carefully place the sealer in the right place. When we do that, there is a better chance for that tooth to recover. If it doesn't recover, then our next step will be the apical surgery. The 6-month review is remarkable. You can see the bone healing, the tooth is completely asymptomatic, and the tooth is going the right direction. I've seen lots of colleagues saying, oh, if I treated the tooth and it looks nice, how can I do better on the second time? Don't give up. That's my advice to you. I think we are not perfect, and there are cases that we try our best and we think we are doing. Perhaps we didn't spend much time because we were late. I don't know. Something didn't go according to plan. So we need to look back and say, my notes confirm everything. Am I happy with the treatment, the way it was carried out? Can I improve something? And I think we should try. We should try, because at the end of the day, it's your responsibility of that canal, is your canal, and I think that's what we can offer to the patient in their best interest. If it fails again, we can again offer the surgery, and of course there is a limitation of things you can do, but if you have the possibility to offer those things, I think that's the best way to go. And hopefully your failed cases, because we all have them, you will start to have less failed cases. Of course, that's the idea, but when you do have a failed failed case. You will back to that case to transform that failed case to a successful case. So good luck in your case, and I hope you can apply those techniques as well.